Ready? Start webinar in 3, 2, 1. And I'll give people some time to filter in before I start talking. Hi, everyone. Welcome. We're just giving everyone a minute to get in before starting this session. We're going to give ourselves about 20 more seconds and then we're going to get started. And as Nazreen mentioned, we'd love to see where you're joining us from. Feel free to write in the chat. Okay, let's get started. Welcome, everyone. We are so glad to be having this presentation today, this ECHO presentation titled Beyond Slogans Towards Anti-Racism, Equity, Diversity, and Inclusivity in Palliative Care. And I'm joined here with Dr. Nadine Persaud and Dr. Amit Arya. Welcome. Before getting started, just some background information for those of you who are new to the Palliative Care ECHO Project. This is a 5-year national initiative that's supported through Health Canada. And the goal of this project is to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients and their families with life-limiting illness. And we've provided the website there, and my colleague Nazreen is going to provide a link in the chat. This is a website that contains all of our upcoming ECHO sessions, as well as recordings of any of our previous sessions. And we now have hundreds of recordings of previous sessions, so definitely check that out. Also just wanted to mention that while the Palliative Care ECHO Project provides opportunities for ongoing professional development, it does not replace the foundational training on the palliative care approach that can be provided through programs such as Palliative Canada's LEAP courses. So this slide just contains some info, and if you haven't yet done your foundational training, please check out the link that's there. Nazreen is going to add that into the chat, and that'll give you information about this these great LEAP courses. And now on to introductions. My name is Holly Finn. I'm a project management professional working at Palliative Canada. For those of you in the audience who are LEAP facilitators, I'm sure I speak a lot with you guys. And my passion is in project management, and I'm helping with the delivery of LEAP sessions, supporting ECHO. And so I'm really glad to be here. And I've mentioned Nazreen's name a couple times. She's joining us today to help us out with any, oh, my mic is windy. Okay, that's good to know. I won't be presenting for long, and I can turn off the fan that's above me. That's probably what it is. Maybe while I'm fixing the fan, I can hand it over to Dr. Persaud so she can introduce herself.
Hi, so my name is Dr. Nadine Persaud. I am the Executive Director of the Kensington Hospice and the Senior Director of Client Services at the Kensington Health. We are located in downtown Toronto, in which we have a 19-bed hospice, which is one of the largest hospice in Toronto on one site and one of the largest in Canada. And we also run a 350-bed long-term care home and a community program that services about 1,000 people a year living at home in the community.
Yep. Hey everyone, my name is Dr. Arya. I'm a palliative care physician. I work with my colleague Dr. Persaud at Kensington Health, and she just described Kensington Health as you heard. I'm the medical director of a new program, a specialist palliative care and long-term care outreach team running out of Kensington Health. I also work as a palliative care physician at North York General Hospital in the GTA area as part of the Freeman Center for the Advancement of Palliative Care, and I hold faculty appointments at the University of Toronto and McMaster University.
Wonderful, great to have you both here. And before we let them kick into gear, we just have to get some disclosure slides out of the way. Just so you know, Palliam Canada is a non-for-profit organization that receives partial funding through Health Canada, and we do generate funds to support our operations, research and development through our course registration fees for LEAP, and also sale of the Palliam Pocketbook. And we've checked in with our presenters leading up to this session, and they confirmed that they have no conflicts of interest to disclose. And before they get started as well, we want to go through some reminders. So we have enabled the chat for the first part of this presentation. We would love to hear your chat, your comments and feedback along the way. We do also have a question and answer function through Zoom. So please, if you have any questions, try to remember to put them into the Q&A. That way, when it comes to the last 15 minutes, when they go over our Q&A portion, they'll easily be able to find everything there. That'll help keep us organized. This session is being recorded, and this recording, along with all the slides, will be emailed to you as well as anyone else who's registered for this presentation within the next week. And if you are writing questions or putting anything in the chat, just remember not to disclose any identifiable personal health information during this session. And I will turn it over to our presenters. Thank you.
Hey, welcome everyone. We thought we'd start off with a bit of a happy announcement and an explanation. As you know, in the original sort of plan for this presentation, our colleague, so both Dr. Persaud and myself work with Dr. Nadine Persaud, and he was going to be presenting as part of this webinar. He couldn't make it, and actually on the screen is the very happy and exciting reason why. It's because he's a new dad, and I'm sure he's busy right now changing diapers, burping, swaddling, all the exciting things that come with a new dad. Just a few days ago, baby Nia was born, and we wanted to just start off once again with this exciting announcement that our colleague, Dr. Persaud, I'm sure many of you know him, is a new father and going through that experience for the first time. Moving on to the next slide. We'll start with a land acknowledgement. Both Dr. Persaud and myself, we're joining you from Toronto, which is the ancestral traditional territories of the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat, and the Mississaugas of the New Credit. I encourage all of you to think about, a land acknowledgement about, like where you're joining us, for this talk today. And of course, part of work in anti-racism and anti-oppression is to also, identify anti-Indigenous racism, which is very prevalent in society as well as in the healthcare system, and work together to dismantle it. Moving on to the next slide. So in 30 to 45 minutes, we're going to try to talk very briefly about this very important topic. We're going to speak about how inequity and discrimination, including racism, are built into palliative care as a system, and we're going to provide you with some practical steps to try to provide more culturally safe and anti-racist palliative care. I'll start, before I get into the actual content of our presentation, I'll start with a bit of a trigger warning. So, of course, I wanted to recognize that for many of you, this conversation today might be quite triggering. For people who are racialized, perhaps you've experienced racism yourself, systemic racism for you or your family members in the healthcare system or in other parts of society, and this may elicit trauma, PTSD type reaction, emotional and physical symptoms. For people who are white, this may be something that's new and something that you haven't really seen discussed extensively. When we're talking about redistribution of resources, many other things which are important, identifying and naming racism, all of that can be quite triggering. And, the speed at which we're talking about things, may also be not suited to where you are at. And once again, we have no choice but to talk about this important topic in 30 to 45 minutes. That may be too slow for some of you and it might be too fast for others. So take a moment if you need to kind of, turn the video off, step away, just to collect your thoughts. Please do that. That's very, very important. And we want this to be something where we're all speaking about this collaboratively and collectively. Please feel free to put any comments in the chat. We want to make this interactive, even though I guess questions will more formally be reserved for the last 10 to 15 minutes of this presentation. But please feel free to put any comments, feedback, suggestions, experiences in the chat so we can try to make it as interactive as possible. So we'll start with a bit of a historical context about racism in healthcare. And, I would hope that many of you are, maybe already aware of some of these experiences. And this is not a brand new topic, but historically, of course, there are many, many examples and actually many books, textbooks already written on, racism in healthcare. And we're just going to present, just a few of those examples, which may start to, present this topic to you. So one of the examples that, I've learned about is, about Dr. Sims, Dr. James Marion Sims, who is actually regarded as the founder of modern gynecology. And actually, he developed many sort of modern gynecological surgical procedures by operating on enslaved Black women without consent and without anesthesia. So in fact, in a very, very gruesome and cruel way is how we've arrived at modern gynecology. And this is just one example of historical racism in healthcare. And I can share with you, when I went through medical school and I went through my obstetrics and gynecology block, that's not something that I was taught at all. It was not even mentioned in our textbooks. Secondly, here's another example. This is sort of a Canadian example, and we often are thinking sometimes that racism is something which is more prevalent in the US, but this is, pablum or baby formula. And many of you may not know that, about how pablum was developed. So pablum was developed out of Sick Kids Hospital, Sick Kids Hospital in downtown Toronto by two quite celebrated pediatricians, Frederick Tisdale and Theodore Drake. And actually, it was developed through experimentation on Indigenous children without their consent. Through the process of arriving at the formula for pablum, they actually killed many Indigenous children. Many Indigenous children and communities suffered as a result of this coerced experimentation without consent. And openly, these two pediatricians talked about administering colonial science because they viewed Aboriginal bodies as experimental materials, and they talked about residential schools and Indigenous communities as types of laboratories. And this was even after World War II and Nuremberg. So quite a recent example about racism in Canadian healthcare. Recently, there was this article written in the Canadian Medical Association Journal, which you could look up, about Dr. William Osler. Once again, presenting a bit of a physician perspective here. When I went through medical school, Dr. William Osler was, and probably continues to be to some extent, a revered physician. We were taught his physical examination techniques on a regular basis, but we weren't really taught about the context in which he practiced and many of his beliefs, which are very, very important for us to all know about. I mean, in the GTA here, there's actually a hospital system named after William Osler as well. So actually, he thought about, he openly talked about a white man's dominion. He talked about racialized immigrants as having less rights than, white people in Canada. He was a member of the American Medical Association and supported them from excluding racialized qualified physicians from being included in the American Medical Association. So this is once again another example that we should all look at. And, I'm reading in the chat that somebody's written about the immortal life of Henrietta Lacks. That is also another example of, overt racism which occurred in a historical context. Moving to the current day, we're once again going to focus on racism in Canadian healthcare as a system. And definitely we know this is proven through data and multiple experiences on the front lines that racialized communities are more likely to experience inequitable healthcare from the moment of birth through life, extending into end of life and palliative care, which is of course going to be our focus today. But whether we look at access to primary care, access to cancer screening, access to OB care, we know that racialized communities are, once again, less likely to receive good access. And good access is not enough, right? Provision of care also matters too. So the provision of care is often not appropriate as well. The COVID-19 pandemic was, of course, an event which highlighted and exacerbated many of these inequities, whether we look at availability of testing, availability of the vaccine. Racialized communities were disproportionately impacted by COVID-19, especially in the earlier waves. But in fact, many public health authorities in the beginning refused to collect race-based data and overtly said race doesn't matter, but then were forced to after there was a big outcry from racialized communities, and it evidently became clear that resources were not being provided in an appropriate way, which led to higher death rates, higher hospitalizations, and a greater burden of suffering. There are many other examples, and for the interest of time, we won't get into that, but I encourage you to all read the story of Joyce Echaquan. You can read about the experiences of Black people with sickle cell disease, and so on and so forth. You can simply just do a Google search and look at racism in Canadian healthcare, and you'll find many, many examples in the current context. So this brings us to this classic conversation. Well, is race a social determinant of health? And should we actually be centering our discussions around race? And no, it is actually racism. And once again, we have to make a proper diagnosis. I mean, we have to name the phenomena. And I hope for all of us as palliative care providers, that should be pretty easy. We talk a lot about, not skirting around, death and dying, naming death and dying, being direct in our conversations. And the same applies here. If we don't make a proper diagnosis and we don't name the phenomenon, then we can't actually, address the issues that need to be addressed. We can't actually work to, dismantle these disparities. And one example that I think of in this context, where we can explicitly illustrate that it's not race, but it's racism, is when we look at Indigenous communities and how they're disproportionately impacted by tuberculosis. So for example, it's estimated in Canada that Indigenous people actually have almost 300 times the risk of getting tuberculosis as compared to non-Indigenous persons. And in spite of the fact that Indigenous people make up 4% of the Canadian population, they make up 19% of cases. So there is nothing unique in the, in the genetic code of Indigenous people that makes them predisposed to tuberculosis. In fact, this is centuries of inequity, violent structural racism and disparities which continue to this day and result in poor health outcomes, result in greater suffering and death. So once again, we have to name the phenomenon. The reason for this is not race, but racism. Now, this is an important slide because we talk a little bit about, white supremacy in the slide, but also about overt versus covert racism, overt versus covert white supremacy. So first of all, what is white supremacy? White supremacy is a social, economic, and political philosophy which says that people of European descent are superior and systems are made to continue to their advantage. And definitely we know that exists in the healthcare system, that exists in palliative care as well. Now, overt forms of white supremacy are often what people think about when they're thinking about racism. So they think about, racial slurs or epithets, protests by the KKK in the US, Donald Trump, phenomenon and things like that. But in fact, that's just the tip of the iceberg. And we need to do much more when we are identifying racism. We need to look at the covert forms of white supremacy, which in fact are more normalized and they're more socially acceptable in healthcare and in society broadly. So obviously there's many, many examples of covert white supremacy, which you can see on the slide in front of you. But some of the things that, we regularly see, and I think would apply to palliative care, would be English only initiatives. And we're going to talk a little bit about that. Lack of access to interpretation, discriminatory hiring practices. When we look at leadership in our healthcare system, in palliative care, is it really representative of the people who need the care the most, the people who are the least, representative generally? Denial of racism is, of course, another form of racism itself. Denial of white privilege, denial of white supremacy, all of that is very important. Blaming the victim, so thinking that people are choosing greater suffering and death is, of course, another form of covert white supremacy, and we're going to talk about that as it, exists in palliative care as well. So once again, the vast majority of racism and white supremacy is covert rather than overt, and that's really what we got to look at, what we have to look at. Trying to switch the slide. So when we think about racism, a lot of racism now is not biological racism. It's not overt, but rather it's unconscious. It's really something that is, it's a bias that we all have to some extent, but our unconscious thoughts influence, our actions, they influence our words, and this directly impacts healthcare outcomes. In fact, you can Google up implicit bias in healthcare, and you can find a range of, clinical research which talks about this phenomenon. And once again, we will share examples about how this applies to palliative care, where racism once again exists as implicit bias, and this directly impacts, clinical decision making. So implicit bias is essentially attitudes, stereotypes, things have been sort of normalized that once again, affect our, our actions and decisions in an unconscious manner. So, this, once again, is a very important racism that we have to, discuss. And you can go to this link, which is through Harvard University, where you can actually all do an implicit bias test as well to figure out your own implicit bias, which, can be very helpful to understand. So how does implicit bias create structures of racism? So, once again, I'm naming racism. It's not race that we really have to look at as the critical factor. It's racism. So implicit bias over time feeds into the structures, right? The leaders, the people who are working in the system, whether it's any type of system, the justice system, the education system, and the healthcare system, the people who are working in that system have implicit bias, and therefore create a system which, once again, has racist tendencies, leads to these disparities, and creates structural racism. So structural racism, therefore, becomes so greatly interwoven into our society. It influences many aspects, in fact, all aspects of our lives, all aspects of society, and definitely it impacts the healthcare system as well, and it leads to disproportionate suffering and death for people who are racialized. And we will speak about that from a palliative care context. So, there is emerging data looking at racism in palliative care in Canada. One of the problems in Canada is that we don't collect race-based data. So often we have to use other surrogate markers. We have to look at country of birth. We look at language, for example, and all of these show across the board that there are disparities in how palliative care is delivered. And, you can look up these studies and read them yourself. But essentially, for example, one of the studies looks at, immigration status and end-of-life care in Ontario. And this recent study sort of found that actually country of birth was the biggest driving factor to whether you received aggressive care or not, and whether you received a palliative approach to care at end of life or not. And for example, if you were born in South Asia, if you were born in East Asia, if you were born in Africa, you were much more likely to die in the ICU, were much more likely to get dialysis at end of life, a tracheostomy. And if you were someone who was born in Canada, or preferably even somebody who was born in Northern or Western Europe, you actually had better healthcare outcomes when it came to end of life care. So this is something that has been looked at. And I wanted to address one thing up front with this slide is that, well, first of all, we know historically probably why this is the reason is that, because palliative care, like the rest of healthcare, had primarily white founders, Western approaches to palliative care have been more normalized and, sort of more culturally safe, culturally humble approaches, are just not available. People don't have the training and expertise in order to provide those approaches, and they aren't addressing these disparities head on. So that's one thing. And then the other thing is that what we often hear is this sort of assimilationist perspective where it's sort of presented as a preference and, sort of saying that, well, we're giving the care that people want and everybody has equal access to care. And, many recent immigrants don't want palliative care. And that is far from the truth. There is study after study showing that when we ask people who are racialized what type of end-of-life care they want, what type of palliative care they want, of course, nobody says that they just want to end up in the ICU. They want to end up connected to machines and tubes. They want to suffer. They don't want proper pain management. Nobody says that. Study after study actually shows that people want palliative care. And in fact, what we find in the literature is they're not exposed to palliative care. They're less likely to be involved in advanced care planning. And they don't find palliative care as it's delivered safe. They don't find that their needs are met. They don't find that the communication style works. And of course, there are disparities in terms of access to resources. So there's lots of literature, lots of studies that show that this is not a preference, but rather, a problem in the actual system and a problem at the micro level when it comes to training and education for healthcare workers. Here are some examples of racism, specifically in palliative care and pain medicine. So I'm not going to read up all these examples. I'm just going to, breeze through this once again in the interest of time. But, essentially, for example, racialized patients with metastatic cancer have been found to be 3 times less likely to receive appropriate pain management. There's lots of research that shows that Black people, unfortunately, are much less likely to receive any type of pain management, even in the case of very serious injury. There's research, for example, that shows that if you're Black and you're admitted in the ICU, your physician is much less likely to spend appropriate time with you, and in fact will spend less time with you. There's a very recent study here from from the US in 2016, which actually showed that 50% of white medical students and residents endorsed incorrect racist beliefs about Black people. In fact, they felt that Black people had thicker skin, which led to undertreatment of pain. And in fact, that itself has a very historical context where experimentation was done on Black people without their consent historically in the US when they were enslaved, where it was thought that they had thicker skin. And once again, this is even influencing our healthcare system today. It's even influencing how healthcare workers are practicing and leading to greater suffering and death. Just trying to change the slide. Okay, so how does white supremacy affect clinical care? So once again, we're talking about some of the reasons, but I will re-emphasize that this is not a preference, but rather systems level issues that we all have to identify and dismantle. So language barriers, these are some examples, and I hope some of these will be obvious, but language barriers are actually a very common way that, of course, people don't receive appropriate care. They don't even know their options. If you're somebody who's racialized, admitted in an Ontario hospital, as a recent study showed, if you don't speak English as a first language and you're somebody who's frail or elderly, a recent study actually showed that if your physician does not speak the same language as you, so for example, if you speak Mandarin, for example, and your physician speaks English, your death rate is actually significantly higher. It's about 50% higher. Your risk of falls, other adverse outcomes is higher. And that shows us how important communication is to healthcare. And we all know that as palliative care professionals. And I'm also shocked about, for those people who work in the community, who work in home care and hospice, actually, many of us don't even have access to interpretation services at the point of care and at the bedside. So that in itself is a huge problem. We know that often people aren't trained in how to disclose information appropriately and think that there's this one size fits all approach. And we're taught in this Western, autonomy focused approach where the focus is on the individual and, the focus is on disclosing all health information so that people can make their own decisions. And that's actually not how most cultures in the world make decisions. So many times people indirectly talk about death and dying. A lot of the times people, will defer to their families or, defer to their community members and loved ones to make decisions for them. We often think about, like the broader picture here where many people who are arriving in the palliative care context, they may have had less access to healthcare for their entire life. They may have suffered greatly due to less access to cancer screening, less access to primary care, and so on and so forth. And then with that, they're often in a scenario where then they're being presented with palliative care options, and they may just have less trust in the system, at large, at that time. So this is something that's very, very important for all of us to address and look at. So we have to look at the big picture. We have to look at how racism as a system is intertwined with white supremacy and affects clinical care. Right. So I'll hand it over to Dr. Persaud.
So when we think about racism in palliative care, when we often think about palliative care, we think about palliative care as something that is incredibly beautiful, where we have many meaningful moments. Often when I'm at meetings about hospice care, palliative care, we talk about the magic of palliative care, what makes it look so special. But when we actually look beneath the surface of what we do every day in palliative care, and we look at the people that we provide, what we know is that if you are white, if you are rich, and if you have cancer, you have a higher likelihood of accessing palliative care. Dr. Sandy Buckman and I did a presentation about 3 or 4 years ago about the westernized model of palliative care and how that's impacted people of color and people who are structurally vulnerable in how they receive palliative care. And if you look at the palliative care was started in Europe. It was started by Dame Cicely Saunders. It's a very westernized model, and we've adapted it across the world. And Dr. Buckman has done a great amount of work in Guyana. My parents are from Guyana, and if you go to Guyana, they would say, we don't have palliative care. We don't have hospice care. But they actually do. People die at home in the community, maybe not with the same level of care and medical care that we have here, but they have family gathered around them. They have volunteers gathered around them, where people actually die at home in their community. So we know health disparities are widely documented across the healthcare sector, and differences in access to care, quality of care, and health outcomes persist across demographic groups. Lack of communication regarding values and preferences and beliefs and what's important to individuals often ends up in aggressive treatment and unmet needs, unresolved symptoms, hospital burden for people who are at end of life and people who are structurally vulnerable. We know that some racialized children who are living in poverty will likely have poor health outcomes. Palliative care services are often in really big hospitals, so there's a lack of access. And what we know is that palliative care is a fundamental human right, and therefore research, policy, clinical practices all have to be viewed through a lens of equity and a lens of justice to understand that the distribution of structural barriers and challenges faced by particular groups must be understood and identified even before we can talk about a palliative approach to care and what palliative care means. We really need to understand who the people we are served, where they've come from, and how their life and their experiences have gotten them to where they have been. And I don't think we do a lot of that in palliative care. When we look at how we define racism, Dr. Ibram Kendi has done a really great book on, and he says racism is one who is supporting a racist policy through their actions or inaction or expressing a racist idea. So often we think, well, if we're not participating in it, we're not saying anything, we're not really contributing to racism, when that's actually pretty untrue. He goes on to define racial inequity, racial policies, and racist ideas. He says that racial inequity is when two or more racialized groups are not standing on approximately equal footing. He identifies a racist policy as any measure that produces or sustains racial inequality between racialized groups. By policy, he has written and unwritten laws, rules, procedures, regulations, and guidelines that govern people. A racist idea is any idea that suggests that one racial group is inferior to superior to another racialized group in any way. Racist ideas argue that the inferiorities and superiorities of racial groups explain racial inequities in society. This is a really great book, and we do suggest you purchase it or read it or borrow it. It's helped us quite a bit in our own practices. How do we define anti-racism? So one who is supporting an anti-racist policy through actions or expressing an anti-racist idea. The opposite of racist isn't not racist, it's anti-racist. What's the difference? One endorses either the idea of racial hierarchy as a racist or racial equality as an anti-racist. One either believes problems are rooted in groups of people as a racist or locates the roots of problems in powers and policies as an anti-racist. According to the Alberta Civil Liberties Research Center, anti-racism is the active process of identifying and eliminating racism by changing processes, organizational structures, policies, and practices and attitudes so that power is redistributed and shared equitably. We need to take on the responsibility at a system level to shift to an anti-racism and anti-oppressive approach to care. The shift is needed to understand that the onus is not on individuals, but on the interconnectedness of our systems and how we view racism, prejudice, and oppression. We cannot shrink this shift in our own hospice palliative care systems. Our healthcare systems are deeply rooted in biases, and as a result, study after study has shown that Indigenous peoples and Black individuals are racialized, oppressed groups who are often being harmed and mistreated by racism within our healthcare system. When we look at the way we provide care in palliative care, even in our hospice, there's so much unconscious bias at times. We supported a young woman who was uninsured, and she was from the Caribbean, and she came here to die with us. And she was a refugee. She had a really difficult story. And a lot of what she was doing wasn't really understood by staff. So when someone died, Every time someone died, she would go in the room and she would stand by the door and she would kind of clasp her hands and be part of it. And staff were coming and they were saying to me, Nadine, like, she's breaching policy, she's breaching privacy. This is a issue with confidentiality. We don't understand why she's doing this. It's so rude. And we had many conversations about this. And I said, guys, let's take a step back. Let's look at a trauma-informed lens of care. Where has this woman come from? She's come from the Caribbean. As I said earlier, with the work that Dr. Sandy Buckman has done in Guyana, and that what I've seen, dying is a social experience. It's something that the community shares. It's something where her being in the room is her sharing that death experience to say, I'm here for you and I'm supporting you. And when we flipped our lens, it was like, oh, that is why she's doing it. So when we look at anti-racism and anti-oppressive and our own unconscious bias, when we're able to flip our lens and look at things through where someone has come from, why they are the way they are, it helps us to provide better care. And going forward, we were able to provide better care and better understand this patient because we took the time to understand how her social determinants of health impacted the way that she provided, or that she was understanding death and dying in our westernized hospice palliative care model. Sorry. So when we look at, a lot of the work that we do, whenever I ask anybody, how do we treat people fairly? What do we do here at Kensington? They say equality is important. And it makes me feel so cringe. I'm like, oh, it's not really about equality. Equality is so different from equity, but as like anything else, equality, equity, trauma-informed care, they all have become buzzwords. So I say to staff often, when you say equality, what that means to me is that if I were to come into the hospice one day and say, I am going to give everybody in the hospice the same pair of shoes because everybody needs to be treated equally, how would that work? Everybody's feet are different sizes. Some people like running shoes. Some people like heels. Some people don't want to wear shoes. What equity means is I'm going to come into the hospice and I'm going to give everybody the choice of wearing shoes or ask them to wear the shoes that fit. So everybody's shoes are going to look different and feel different, and some people may not wear shoes. And that's the difference between equality and equity. It's giving people what they need in order to succeed, in order to get the care that they need. And I think that's where we really need to make that divide between equality and equity and shift away from equality and really focus on equity, as one size does not fit all. And you hear that often at anywhere, so many places in palliative care, well, everybody has to be treated the same and we need to be equal. And it's like, well, no, that's not what we actually need. We need people to be treated the way they want to be treated. When we think of Harvey Chachanoff and his work around, the platinum rule, the golden rule is treat people the way you would like to be treated. The platinum rule is treat people the way they would like to be treated, because I know the way I like to be treated is probably very different from the way Dr. Arya would like to be treated. And I think that's really important as we flip our lens and treat people the way they would like to be treated. So when we look at treating people the way they would like to be treated, we know that everybody's path, although we may end up at the same destination, the way we get there is going to be very, very different. When I look at this is very personal to me because being a woman of color, I can understand what it means to cross that path. And even before you start that race, there are so many things that are holding you back and pulling you slower to get to your final destination. And I know that when you get to that place, it makes you feel it's a different kind of success because it wasn't a one straight ride. And that doesn't mean that if you're white, it's an easier ride. That doesn't mean that by any stretch of the imagination. It just means that there are disadvantages that are going to be there even before we start that race. Recently at our hospice, I had a very new nurse. She was from India and she came to me and she said, oh, I read about you online and I'm so proud for us. And it made me step back for a minute. I was like, what does she mean by she's so proud for us? And I think that when you think of a community of what it means to be a person of color, to get to certain places, there's an understanding of what it takes to get there. And I think we have to understand that although it may be the same distance, same destination, the journey there is very, very different for every single person crossing that path, and understanding that we need to understand and treat people differently based on their journey and based on where they've come from and based on the innate things that just they are carrying even before they start that journey is very important. So at Kensington Hospice, we've taken on a huge stance to become a hospice that prides itself and that is built upon anti-racism and anti-oppressive practices. And we've done a lot of work to ensure that the population that we serve fits the postal code of our hospice. So even though across the street, the houses across the street at Kensington go for upwards of $1.5–2 million, which means that the people that live across the street from the hospital are often very privileged. We want to ensure that the people that are dying in the beds of the hospice are reflective of our community, which we know is one of the highest marginalization rates in Toronto. So at the hospice, we have 19 beds. And we really started health equity about 2 years ago, a commitment to say that we are going to really focus on health equity. I hired Dr. Nahid Dasani as our clinical health equity lead, and we've started our journey to become better. We got here through courageous leadership. COVID really gave us a catalyst to say we need to do this now. A funding commitment to say we need to actually put funds towards this, because if it's important, we have to invest in it. Not one tragic case, many tragic cases of people that were structurally vulnerable that didn't get access to our hospice, that got access to our hospice. And then by the time we figured out how we could properly care for them, it was too late. And by a dedication to really build a center of excellence for anti-racism, EDI, and hospice palliative care. So we started a 5-step iterative cycle to implement EDI at the hospice. And our first step was to define. We redefined buzzwords: equality, equity, trauma-informed care, racism, race, oppression. We looked at all the buzzwords and we looked at it. Cultural competency, another cringe. How can you be competent in culture when it is so complex? We talked about cultural humility and cultural safety, and really shifting away from the words that have just become very innate in who we are and what we say. We ensured that language was clear and simple, something that everybody can understand and everybody can move towards not only understanding it, but feeling it. We changed policies to ensure that the language we use was consistent throughout the organization. Step 2, we looked at what EDI is. We know diversity is where everybody is invited to the party. Inclusion means that everyone gets to contribute to the playlist. And equity means everyone has the opportunity to dance. And this was something that we used with staff when we brought them in for one-on-one interviews to ask them, what does EDI and what does equity mean to you? And they started to talk about equality. This is what we shifted towards. And this is a very basic example that is kind of like that light bulb where it's like, yes, that's what it means. And it breaks it down in a way that's really simple. Step 2 was measure. Measure was really important. So we created socio-demographic indicators to better understand individuals being served. We created key performance indicators to accurately measure who we're being cared for. And we updated our balanced scorecard, which is our quality scorecard, to show us who we are serving, how we are serving them, why we are serving them, when we are serving them, to really tell us a story. So what it told us, our sample at first was 163, 66% of the people that we saw came from hospital. 83% of the people that we saw were white. 93% of the people that we saw had independent housing or were housed. 67% had no diagnosis of a mental health illness. 80% spoke English. 80% had cancer. And this just did not make sense to us. We looked at these stats and we're like, there is a disconnect between who we're serving and who we're meant to serve and what our community, what we're doing for the community. So we started with we conducted one-on-one interviews with staff to understand what they understood about EDI. We presented to leadership and board to get their idea of what it meant. So we really engaged the front line. Dr. Dasani and I actually started our work at the front lines and we moved our way up to the board. Often in these processes, we start our way at the board and we move our way down, but we thought, who best understands what we do and who we serve than the front line? So we flipped it on its head and started from the front line and moved our way up. We were really innovative in what we did in terms of health equity and really looking at our indicators and creating scorecard measures. We looked at our referral process and we created equity-informed triage pathways so that we would always ensure that people who were disadvantaged, people who were structurally vulnerable, were being looked at and prioritized to have access to hospice palliative care. So it wasn't a first come, first served basis. It was, does this person have a house? Do they have a support system? Do they have family or friends who can help care for them? If they do not get access to the hospice, are they likely going to die in an emergency room? We looked at care planning to ensure that the social and structural determinants of health were implemented into people's care plans. And we're currently conducting a systematic review of EDI in hospice palliative care. So I think someone named Victoria, I believe, asked a question. There is data, but there is not a lot of data on what it means for racialized groups accessing hospice palliative care. And we're seeing that through the systematic review that we're conducting. So we're conducting this review to really understand what is the literature telling us about access to palliative care for racialized groups. And step 5 was really building capacity. So we've built community partnerships with ECHO, the Inner City Health Associates. We have a health navigator that we share with the PEACH program to support people who are dying of homelessness on the streets. And we do direct pathways, and we have direct transfers from the streets into our hospice. A lot of outreach and awareness through our health navigator role. We're currently hiring a peer worker through a grant that we got through Healthcare Excellence Canada, and a lot of training and education. And not just training and education that just comes from us having staff come to didactic, info sessions, really sitting at the bedside. I do a lot of bedside support. I do a lot of bedside clinical care. We have as many people coming in and doing that as well. So we really train at the bedside, and because we know that people learn best by integrating theory to practice and seeing practice and theory integrated. And since the work that we've done with many of these different things, we've recently ran the data in March. We've seen a 10% increase in community-based referrals. So this is people who are living in the community through shelters, community referrals, the home and community care. We've seen a 6% increase in racialized residents served. We've seen a 2% increase in residents who are considered underhoused, a 20% increase in residents who are living with a mental health illness, and a 9% increase in non-English speaking residents. Currently, right now, so we have made a commitment that a minimum of 25% of the people that we serve at Kensington Hospice will be structurally vulnerable, a minimum. Right now, in our 19 beds, 36% of people in the hospice are structurally vulnerable. There was a time when that percentage was 2%. We've done this work to show that we do not need specialized hospice services to support structurally vulnerable people. We've done this work to say all mainstream hospices can support people who are structurally vulnerable. They should be supporting people who are structurally vulnerable. We just need the commitment to do it, the passion to do it, the resources to do it, the leadership to do it. All mainstream hospices across Canada should be supporting structurally vulnerable population. It does not take special hospices. It takes a hospice, it takes people, it takes commitment. So we're doing this work to show that mainstream hospices can support people who are structurally vulnerable the same way Kensington has done and continues to do. And if you want to see an article that we've just done, if you Google Kensington Hospice, you'll see the article that's come up of a man who is structurally vulnerable, and how this can be done in mainstream hospices every single day. We can do this work, we just have to commit to it together. So I'm not going to go through this, but I'm just going to speak to it. It's about a shift of how we shift away, how language is important, the words that we use are important, and how what we mean by what we say social determinants of health, what we mean by what we say BIPOC are higher risk for. So racism increases the risk for certain things. What we mean by implicit and unconscious bias. That's a big one for me. I think, as a woman of color, I continuously heard your tone, you're sometimes very direct and you're very strong. And I used to go home crying, and I used to be like, what does this mean? I don't know what this means. Like, I don't know what I'm doing wrong. I don't know how I'm speaking differently. And I had many conversations with Dr. Dasani and Dr. Amit, Arya, and Dr. Arya, and they said to me, Nadine, those are microaggressions. And microaggressions are a form of racism where women of color are often tone policed for being too strong, too direct. Like, what's wrong with a woman being strong and direct? Would we ever call a man strong and direct? So what does it mean by unconscious bias? And how do we look at even microaggressions of what we may say to people every day and pull that apart to recognize that within ourselves? Dr. Arya, I'm going to hand it over to you.
Yeah, sounds good. Sounds good. So yeah, we're a little over time, so hopefully we can wrap up soon to allow some further time for discussion, questions, and so on. So these are just some examples of how to become an anti-racist palliative care clinician, and we provided you hopefully through this talk with some of the fundamentals, where obviously the first step is to engage in critical self-reflection, understand what racism and anti-racism actually is, and think about what are some of the ways where you can identify racism and then start to dismantle it. Once again, there's these points which I'm not going to read out verbatim on the slide, but one way that I often think about this from a palliative care lens is that actually working in palliative care on the front lines, many of us are already kind of wired to think about advocacy as a core tenet of our work. On a day-to-day basis, I see my colleagues, calling a home care coordinator so that they can try to get extra access to services. I see, my nurse and PSW colleagues staying late to try to manage suffering for a patient or speak to a family that's grieving. These are things that we see, all the time. So I think we have to extend, when we're talking about suffering, we have to think about suffering more broadly, where, of course, people may be suffering due to lack of access to palliative care, due to understaffing, many, many different issues. But many people are also suffering because of systemic racism. People are also suffering because of, lack of housing, lack of just the bare necessities of life. So it's very important when we think about becoming an anti-racist palliative care clinician that we think about, all causes, from which people are suffering. We talked a little bit already about, race-based data, healthcare outcomes of racialized people, how they're impacted throughout, like their life from birth to death. But I wanted to focus specifically on one point here, which I think is very important to me because I do a lot of research, especially on integrating a palliative approach in long-term care. But, a lot of the times we don't look at racialized participants. A lot of the participants in these studies are actually white participants who are English speaking, who once again don't represent the people who are actually in most need of palliative care. And then, the people who are actually on these research teams are most likely to be white. The people who are on the editorial boards participating in the peer review process are most likely to be white, and so on and so forth. So I think we have to look at how we've actually generated knowledge in palliative care, what our fundamental studies are, and who was included in those studies, who published on those studies. So very, very important. There's some obvious things, and I think one of the most obvious low-hanging fruits that you probably have in your practice is to use professional interpretation services at all times to ensure safe communications. But beyond that, of course, we need to look at who's actually providing palliative care. Are we, in our own hiring practices, training practices, when we look at support staff, are those actually the people who relate the most to the population that they're serving and relate to the highest needs population when it comes to palliative care? I think that's very, very important. We can go through all types of systemic and institutional policies, and my colleague Dr. Persaud has talked about her and Dr. Desani have gone through this extensive review process at the hospice in terms of how they admit people to the hospice and how they provide care. We can sort of look at the cultural and spiritual practices that we support for racialized people as well. I think it's important that we think about this of course, as not something that is a one-time course or a one-time, committee work that's on the side, but as Dr. Persaud has said, something that is integrated into our practice at all levels, whether if you're someone who only works at the micro level and just provides patient care, this is something that you should be thinking about with all your patient and family interactions and, interactions with community members. If you're somebody who works at a more organizational level as well, where you're in leadership, you're on committees, you're trying to, influence change, this is something you should be looking at as well. And of course, at the macro level, when we're looking at government policies, we're looking at how provincial and federal governments fund palliative care. This is also something which is very, very important. So once again, this is more about a lifelong process, which requires daily commitment. As Dr. Persaud said, of course, we need funding from our organizations. We need funding from the government as well. And we need this issue to be prioritized in order to look at palliative care. Once again, palliative care for us, it's not just a job for many of us, or I would hope for all of us, it's a calling, it's a passion. And we should be looking at palliative care from a human rights lens for sure. So lack of access to palliative care is a human rights failure as well.
So when we look at trauma-informed care, I'm going to share a story because I think I can do it in a more succinct way and really get the point home of what trauma-informed care means. We were supporting a man who was experiencing homelessness, and he came into the hospice and he loved singing. He would sing up and down the streets all day, and he dropped his stuff off and he's like, okay, I'm leaving. I'm going to sing. I'll be back around 3 a.m. And the staff called me and they're like, he's leaving. He wants to leave. He's coming in at 3 a.m. We can't support him. He doesn't want to stay. And I said, what do you mean? He's like, he's leaving. He's packing his stuff and he's leaving. And I said, hey, give me a minute. I'm coming over. So I came over. He had his one grocery bag on his shoulder. And he's like, you know what? I don't want to stay here. I'm leaving. I want to sing. And I said, can you just sit with me for a minute? And he didn't sit. I sat, and he stood like looking down at me, and he said, well, like, I don't want to be here anymore. And I said, okay, how can I help you sing? And he looked at me, and he put his bag down, and he sat down on the chair beside me, and he said, now you're speaking my language. Singing gave him the ability to feel as if he was giving something back to society. He had been through so much trauma that this is what helped him. And I said to him, and I said to staff, this is in jail. He can come in and out. And I explained to him why we needed to know where he was and when he was in and out, because we now care about him. And he called his family. 1 week later, he called his mom and he said, Mom, you won't believe it. I found a new family and it's at the hospice. So I strongly believe that when we flip our lens to think about a trauma-informed care, instead of saying things like, what's wrong with them, we say, how can I support you? What are you experiencing? What have you experienced? What have you experienced that is going to help me care better for you? We provide better care. And that's what trauma-informed care is. People think that it's some big, huge, like, you have to do all this work. It's literally human care. It's literally pulling out the task-oriented things that we're usually used to doing and just saying, how can I treat you like a human? How can I understand what dying means to you and make that as meaningful as possible? And I think it's all of our job to inform trauma-informed care. When we think of our work, people often think, well, if you're going to be supporting people who are structurally vulnerable, do you have a harm reduction policies? What's your harm reduction practices? And we're doing a lot of work to build harm reduction into our hospice, but that doesn't mean that like we need to be the leaders of everything else. We need to have policies and procedures to support harm reduction. We're doing it right now. The article that I said, our patient Kevin, he openly says, I love to use drugs and they let me use drugs here. But the problem, we've set up boundaries, we've set up policies and practices. He doesn't use them on site, but we know when he's going out to use and he comes in, and when he's had his mishaps, we would never kick anybody out. We sit with them and say, how can we help you? What has made you slipped? How can we support you? What do you need from us? So harm reduction is more than just, creating a safe space for people to use drugs. It's actually creating a trauma-informed space where we can actually help people live without stigmatizing them, without making them feel like they're going to get kicked out, which often happens to people if they use drugs in certain places. So it's really understanding, how are we trauma-informed? How do we have policies and practices and flexible boundaries to really support this population well?
Yeah, so I think we'll just wrap up our presentation because we're quite a bit over. I hope that's okay. So once again, we emphasized how anti-racism work it's not a destination. It's not something that we can really fully encapsulate in 30 to 45 minutes, or we've gone over, maybe 55 minutes is more of a better approximation. It's more of a journey. It's an ongoing journey. It's a lens that we should apply in all of our work at all levels, something very, very important. And, in conclusion, just wanted to say that obviously bring it back to what we talked about in the beginning, that the starting point is not to be not racist and to be silent, but actually to identify what we're trying to do. And I presented that analogy where we do this all the time in palliative care. We identify death and dying and we name it. So we have to name racism as a cause of health disparities when it comes to palliative care. We have to challenge these disparities then, and then we have to work to dismantle it. This is actually all of our role. And advocacy does come natural to us in palliative care. This is something that we do on an ongoing basis. So I hope that many of you will be inspired by this talk to undertake your own anti-racism journeys where you practice. And thank you so much. Thank you so much from Dr. Persaud and I for attending.
And thanks for all the wonderful comments in the chat. It's so beautiful to see. And what I actually see here is solidarity. I see so many messages coming in, and it means that we're all standing in solidarity to say there's a time for a shift, and the shift is now, and we can all do it together. You can follow us on social media. I'm on Instagram as Dr. Nadine Persaud. Dr. Arya is more active on Twitter. So follow us if you want to continue, being part of our journey. We want to be a part of your journey. And thank you so much for having us here with you today.
Thank you both for being here. This was amazing. I'm loving all the chat. For some of the Q&A, if we weren't able to get to your questions, maybe we can reach out to you afterwards, depending on what we're able to do. But I just want to thank both of you so much for this. We'll see if I can control the screen here. So my colleague Nazreen, she's going to add to the chat a link to our survey. It's really helpful for us to know how you felt about today's session. This is feedback that we look to determine what kinds of sessions we want to run. So thank you for taking the time to do this. We really appreciate everyone doing this, and thank you for the messages. Wow, this is great. Thank you. Thank you to everyone, and we hope you have a wonderful rest of your day.